I'm going to talk about coagulopathies. The good news is you've already had all this in other classes. So I'm just going to give you a short review of some of the conditions we're going to talk about. The first condition is autoimmune thrombocytopenia purpura, which you probably remember from the name immune thrombocytopenia purpura or idiopathic thrombocytopenia purpura, aka ITP. Okay, so what happens in this condition is something causes the platelet level to drop low. Okay, platelets are producing at a normal rate, but the platelet level drops low. The reason is something triggers the macrophages to taste very good to the spleen. Okay, so a virus is essentially a trigger. So the person is going to have a virus. Okay, so let's say hepatitis, mono, or HIV. They have this virus. It makes their macrophages taste more delicious to the spleen. So the spleen acts like a Pac-Man and eats the thrombocytes. So how it is diagnosed, it's with the low platelet level and low megakaryocytes, which are the precursors to platelets. All right, so that's how it's done. Usually, signs and symptoms are going to appear in the mucous membranes. So the patient may have like these spots on their tongue or on the inside of their cheek or even under their tongue. They may have like nosebleeds, which is epistaxis. They will present with a petechial rash, okay? And they'll have purpura and ecchymosis. Now, they're only going to have a low H&H if they're bleeding. So signs and symptoms of bleeding would be very concerning, but typically they'll just have the low platelet level. Rarely they may get an intracranial bleed. So that's like a hemorrhagic stroke. So monitor for headache and, signs of neurological deficit. Interventions for ITP. So if the platelets go below 50K, they say the patient was going to have surgery. They wouldn't operate if the platelets were 50K or below. So this is when you would start monitoring for bleeding. And I'll be going over bleeding in a little bit. You've had it before, but I'll go over it again. They'll take immunosuppressants. That's the treatment for it. They may need platelet transfusions. If you are going to give a platelet transfusion to somebody, usually it's reserved for 10K platelets or less. The reason is patients can develop, well, let me say this. If you infuse the platelets, they're going to get eaten up as quick as they're put in. Okay, so if they were going to have some kind of procedure or something, you would do it right at the time of the procedure. You would put them in. Now, if this doesn't work and it is a problem, the patient is going to have a splenectomy so that the spleen will not be eating those thrombocytes anymore. Okay. Now, the nursing implications of a splenectomy are that they're going to need immunizations 2 weeks before and 2 weeks after, because people with splenectomies, I did a splenectomy when I was 5 years old. And I had, starting when I was 8, is when the pneumovax came out. And I have had my pneumovax every 5 years since that time, okay? And plus I get H flu, and plus I get meningococcal vaccines every time I'm due, because I am prone to those type of infections, and sepsis could kill me. So I'm very good about making sure I stay up with that. So if you have a patient that is having a splenectomy, they either need to get the immunizations 2 weeks before or 2 weeks after their surgery. The spleen provides us with 50 mLs of blood, PRN, and helps us fight infection. So your most concerning would be if somebody with a post-splenectomy has signs and symptoms of infection. Now, in thrombocytopenia precautions, they're the same as bleeding precautions. But I learned something in your textbook that I thought was very interesting, that you are to instruct the patient not to blow their nose. That I knew. But, or play wind instruments. So you can't play like the clarinet if you have ITP. So I thought that was just interesting. And stay away from aspirin, NSAIDs, Those are the most common drugs that cause bleeding. And then the other condition you've had in pediatrics is hemophilia. And there's two types, essentially hemophilia A, which is due to a factor VIII deficiency, and it's the most common. 80% of the cases are hemophilia A. And then there's Christmas disease, which is also called hemophilia B, and that's factor IX deficiency. It's a sex-linked condition that men usually get. And the most common problem is the degeneration of the joint function because they bleed into their joints, right? So they usually present with bleeding from like minor injuries. And there's no cure for it, so they just have to learn how to manage their disease. Now, in terms of bleeding, with hemophilia, you're going to look for like limb swelling, like if they hit their arm and if they hit their arms, just say, okay, you're going to measure the circumference of both arms and look for an increased circumference. You're going to look for, if they had an abdominal injury, you would look for abdominal distension. All right, and then the coagulation study that's abnormal in hemophilia, I'm going to tell you a really easy way to learn this. It's just like heparin. If you take the two T's and turn it sideways, it's the PTT that's going to be prolonged. They'll have a normal bleeding time, which we don't even really do anymore, and the PT will be normal. I wouldn't really worry about that. You want to minimize aspirin and NSAIDs, and I think this goes along well with the kidney diseases because in the kidney diseases, you also want to avoid those two types of medications because it's damaging to the kidneys, but it puts patients at risk for bleeding. All right, now the last condition I'm going to talk about is heparin-induced thrombocytopenia, or HIT. So we're getting better at this, and it happens to people that receive heparin products. Could be like 100 up to 100 days after they receive a heparin product. Okay, so they'll have low platelets. That's why you always check platelets and hemoglobin before you give SC heparin. And then, of course, if somebody's on a heparin drip, you're going to be checking your PTTs or whatever your organization does. Okay. And sometimes patients don't know if they've been hospitalized that they have had heparin through a central line, right? Because usually if they're in the unit or something, they're probably very groggy and sedated, so they wouldn't know they're getting heparin in their central line. Okay, so anyways, you would look for people that are the highest risk. They've been on heparin longer than a week, usually female. They've had some kind of heparin pro-surgical prophylaxis. Usually patients will remember that, getting shots in their abdomen, but they don't remember the central line thing. So you're looking for thrombocytopenia after heparin exposure, and the treatment is to GC the heparin, then they'll get some anticoagulation and just manage the bleeding. Okay, so we're going to talk about bleeding now. And to be truthful, students are usually very good at bleeding. What they're not good at is clotting. So I'm going to talk about bleeding, and then I'm going to talk about bleeding versus clotting, okay? So I think you know all these neurosymptoms because we've been talking about them all semester. Somebody with low perfusion is going to have thirst, dizziness, seizures if it's on the brain. If they're bleeding on the brain, they'll have a blown pupil on the same side, okay? They're going to be confused, have apprehension. Cardiovascular-wise, tachycardia is going to be the first sign with a narrow pulse pressure, dizziness, okay, orthostatic hypotension. You know all these things, okay? And the GI system, so you remember Cullen sign, which is around the umbilicus, gray Turner sign on the flanks. These are indications that there may be some intraperitoneal or retroperitoneal bleeding. Remember, Kerr sign is pain in the shoulder. And if it's on the right shoulder, it could indicate a liver laceration. And if it's on the left shoulder, it could indicate a ruptured spleen. All right. Upper GI bleeding is indicated with like hematemesis, coffee ground emesis, abdominal distension, black tarry stools. And then lower, like if they get hematogenesias, bright red blood, per rectum, and smelly diarrhea. I mean, the smell of bloody stool is characteristic. Um, Renal system, low urinary output, and hematuria, you might see that. And then cool, clammy skin, oozing from IV sites, oozing from their gums. And for the record, I've never taken care of anybody that has died from oozing from the IV sites or their gums. Shortness of breath, hematemesis, they might have that. And then musculoskeletal would be like painful joints and swelling of the limbs that I just talked about. Now let's review bleeding versus clotting, okay? So we kind of just talked about all this bleeding, okay? So the reason I'm teaching you bleeding and clotting is because in DIC, students are very good at picking out the bleeding, but they are terrible about picking out which symptoms lead to clotting, okay? Because remember, DIC is about bleeding and clotting, bleeding and clotting. We have to stop that cycle. All right, so let's talk about the clotting because we talked about the bleeding. Okay, so clotting. If somebody has microthrombi, like what happens in DIC, and it's in their brain, okay, it could be a thrombotic stroke or a ischemic stroke. They might have facial droop, weakness, delirium, and coma, Pulmonary wise, they may end up with non-cardiogenic pulmonary edema, ARDS. They may have a PE, so remember your catfish. CV, they may have an MI, so check troponins and ST changes. In their abdomen, they may have a paralytic ileus and abdominal pain. Renal, they may have anuria or oliguria because a clot can get into the kidney's vasculature and stop the urine production. Okay, and azotemia. So in other words, they're going to have an acute kidney injury. They'll have ischemia, cyanosis, and gangrene. So remember all those things that comprise clotting. And we talked about bleeding, okay? So if the bleeding and clotting is due to DIC, the patient's going to get blood products like fresh frozen plasma, which has all the clotting, platelets, and chiroprecipitate. And chiroprecipitate replaces factor VIII in fibrinogen. FFP is for the prolonged PT-INR or PTT. And heparin, they're going to get heparin for clotting. Now, you're going to have to know these labs in DIC. If somebody's DIC positive, okay, the fibrin split products are going to be elevated. These are also called fibrin degradation products. This is because as the fibrin is used up, it becomes decreased, but it splits into these split products, okay? So this is just the fibrin split products or the fibrin degradation products, same thing. It just means this fibrinogen is getting broken up. So the fibrinogen decreases. The platelet count decreases. The PT and PTT become prolonged. And the INR becomes prolonged or elevated. Thrombin time is elevated, and the D-dimer is elevated because there is some clotting going on. Okay, so review the difference between clotting and bleeding. All right, now we're going to talk about blood administration. You've already had this, which is going to make this awesome. Okay, so first I'm going to talk about chiroprecipitate. It contains fibrinogen, factor VIII, and it is given to people with hemophilia, and it has von Willebrand factor. And I'm not sure why we don't teach that anymore, von Willebrand's disease, but it's not that, I guess because it's not that common. So this is used in the treatment of hemophilia A and any type of coagulopathies as well. Packed red blood cells. Okay, so these would be used for people that have massive trauma. You got to remember it doesn't contain any clotting factors. So if somebody has massive trauma and they're getting a lot of blood, at some point somebody needs to say, what about some FFP? So that they can get the clotting factors. Remember, hang with normal saline only. And lots of times patients will get transfusions if they have chronic kidney failure. All right, so they would get transfusions for a hemoglobin less than 6 or 6 to 10. Don't you hate it when the ATI like just contradicts themselves? But that's what they say. Anybody hemorrhaging obviously would need packed red blood cells. So albumin. Okay, so albumin is a colloid. And let me give you some guidance on when you would give albumin. So albumin is given to people with low protein levels. And you could tell because they have like hypotension. They'll have pitting edema. Okay. So those are kind of some of the things you're going to look at. Like if you think about people in liver disease, they may need albumin from time to time to kind of bring the fluid back into the vascular system. All right, so you give it to patients with low albumin. Oh, here we go. Pitting edema or Insaka. They have low blood pressure, low CVP. That would be another indication of giving albumin. So the goal of it is to bring some of this fluid that is in the interstitium. You put albumin in their blood, and the fluid hopefully is going to go back into the vascular system. All right, platelets. I kind of already talked about this. So you don't give this with your typical Y tubing. It comes with its own tubing when you pick it up from the blood bank. And these go in really quickly. So you deliver it over 15 to 30 minutes. They can get like acetaminophen and Benadryl beforehand. Any of the blood transfusions can actually. When I worked in oncology, we give like a lot of blood transfusions. So there were patients that, they would come back again and again and again. And so we would give this prophylactically before their transfusions. Fresh frozen plasma, another one that's delivered quickly. It has all the clotting factors. Hang normal saline to deliver FFP. And it's given for high INRs when clotting factors are needed. Or you can also give it for hemophilia B. All right, so your pre-perfusion, this is for like packed blood cells. You get, well, for blood products, you would get the consent. Type and cross match. You want to put in a 20 gauge IV, okay, for normal people. And then for older adults, you want 19. That's the highest you can go. So essentially, you're probably looking at a 22 for an older adult if you get asked that on ATI. Okay, I've never personally worked in a place that had 19 gauges. We went by two not inch, but two increments. Okay, so it would go like 18, 20, 22, 24. All right. Patients would need a type and cross match. You're going to assess their vital signs, their skin color, and their urine output. You want to make sure patients are putting out urine before you give them blood. You need 2 licensed personnel to check the blood. Okay, ID the patient. So you want to test the donor and the recipient's blood for compatibility and examine the blood bag label, attach tag. You want to check the expiration date with another RN and expect for any discoloration or bubbles or cloudiness. All right, so you hang with normal saline only, except for platelets, you hang by it themselves. Once you go to the blood bank, you have got 30 minutes to get that blood hanged. So before I went to the blood bank, I made sure my IVs were working because you don't want to have to put in an IV while you're scrambling trying to get everything ready. And I had my Y tubing all set and ready to go. So essentially all I had to do was find another RN to check the blood with me, and then I was ready to go to hang my blood. All right. So once the blood product is up, you cannot hang blood for longer than 4 hours. And for older adults, you want to run it as slow as you possibly can for the whole time. All right. So to prevent transfusion incompatibility, you follow the policy in your organization. So, okay, so you're going to have to know who can get what blood from the blood type, okay? So remember these key points. Positive people can get both positive and negative blood. Rh negative people can only get negative blood. O negative is the universal donor, so everybody can receive O negative blood. AB positive is the universal recipient. So AB positive blood people can get any type of blood. Okay. Patients can only receive their blood type and O negative unless they are AB positive, and then they can receive all blood types. Okay. So the mistake I usually see students make, like if somebody's A positive, they cannot get AB blood. They can get A blood, A minus, A positive, and they can get O positive and O negative. Okay, so that's usually what I see students mess up on. Okay, your responsibilities: educate the patient beforehand. You need to stay in that room for the first 15 minutes, or according to your policies, your organization's policies. Report anything, tell the patient to report anything unusual to you. Reactions can happen in as early as 10 mLs of blood being put in. That's why you have to be there at the beginning. But typically they happen within 15 to 30 minutes. So start slow. And then so you're going to take the vital signs before and then according to your organization's policy. But for older adults, you're supposed to take them every 15 minutes, because if an older adult goes into fluid overload, it's now considered a sentinel event, and we don't want that to happen. Okay, so that you need to stay on top of that. All right, now I'm going to talk about the reactions. So a febrile reaction is going to happen within 2 hours. So the patient's going to have fever, chills, anxiety, tachycardia. It usually happens after multiple transfusions. That's what I was alluding to earlier when I worked on the oncology unit. They're used to getting a lot of transfusions, so we used to just pre-medicate. So if it happens, you're going to stop the infusion, start with a new tubing of normal saline, and you change the tubing down to the hub. Okay, take the vital signs, administer acetaminophen. Hemolytic can occur immediately. They're going to have fever, chills, anxiety, hypotension, tachycardia. And this can also happen with multiple transfusions, so you don't know which transfusion it's going to happen on. They also get like flushing, chest pain, and tightness, but they get flank pain or lower back pain. They're going to have hemoglobinuria, so that means hemoglobin in their urine. So you have to send a urine sample, and nausea. So you're going to stop the transfusion, put new tubing with normal saline, change it down to the hub, check their vital signs, send the bag back to the blood bank, the blood bag, okay? Double check the client and the blood product for their information, and send a urine specimen to the lab, okay? An allergic reaction can happen up to 24 hours after, and they would have like itching, hives, and flushing. So if they were an anaphylaxis, you would give your epinephrine. If they are having a mild reaction, you can give an antihistamine. And then fluid overload. The onset can happen anytime, and especially with older adults, you're supposed to monitor them every 15 minutes. So you're either going to stop or slow the transfusion. Don't stop it and give normal saline at the same rate, okay? You want to slow down, you want to clear out the line, but you want to slow down the rate. Elevate the head of bed, give them O2, and the provider may order furosemide or morphine. So depending on how bad the patient is, you might catch it early. I've done that before, like it was the middle of the night. my patient developed like bibasilar crackles. I missed the S3 sound, but I was able to call and get the provider to order some furosemide and slow the infusion just a little bit so that she could have it, because she was, quite fatigued because her hemoglobin was so low. But then I've had that happen with another patient where I had to stop the infusion. Um, and they did have like crackles and dyspnea, and they were short of breath. But we found it, gave them the medicine, and they were better. All right, so now let me just show you this chart. You see how I have like different colors? So the red color, these are things that are similar, okay? And then this is different with hemolytic. So like students are always like, how am I going to know in an exam which reaction it is? Okay, so look at the timing. I would definitely look at the timing, okay? And I would look for key features like with hemolytic, they're going to get that sense of impending doom. And if you think about it, what happens in hemolytic is the red blood cells start to lyse. So if the red blood cells are lysing, they're essentially losing oxygen off those red blood cells, right? So it makes sense that they have a sense of impending doom. Also makes sense that they have chest pain and tightness and flank pain. Okay, so those are some of the key points that can help you out. And you would give people with hemolytic, if they had a fever, you would give them acetaminophen as well. Okay, and that does it for blood transfusions.